Uh, Everybody always likes cute little titles for talks. And my first suggestion was, are you a hack at extracting? And that didn't sound very good. So we decided to do this extraction hacks, pros, tips, and tricks. And hopefully, I'm sure you'll know a good portion of this, but there may be one gem or two you can take with you. So let's go ahead and get started. So many indications for extractions with our youngsters. If we have persistent deciduous teeth, we need to get those out as soon as we see the permanent. No two teeth should be in the same place at the same time. Or as my former resident, Jessica Johnson says, you wouldn't want two people wearing the same turtleneck shirt or sweater. So it can cause malocclusions if those teeth are left too long. I mean, look at that typical Yorkie type mouth up there. We'll sometimes even take out deciduous teeth if they're maloccluded, but we're really careful with those extractions. And then if we have any supernumerary teeth that are causing crowding, we'll take it out. If they're not, we might leave them. But we need to look for those unerupted teeth, because if we don't get those out, they can form dentigerous cysts. Now, we'll be honest with you, I just reviewed the x-rays of a 6-year-old dog that had an unerupted canine without any bony changes. The pulp was a normal size. It was completely in that lower jaw. We decided to re-x-ray it every year before making this decision to extract. Once they get this bad, obviously you're going to have to extract. Usually in a stage therapy, a few weeks to a month or so in between the two procedures. So with periodontal disease, that's probably our most common reason we look at extractions. And as we look at these teeth, we are actually looking at the disease that's in the attachment tissues, the attached gingiva, the bone, the alveolar bone, the periodontal ligament. We're also going to look at the extent of attachment loss, how much, and even the pattern of bone loss sometimes, decide what to take and what to save. We will also look at strategic extractions, and we'll talk about that a little bit later, where we may take out an adjacent tooth to one of our more strategic teeth, one of the big 8, the canine teeth, the carnasal teeth, to be able to make the periodontal health for that tooth better. Certainly, anytime we see a compromised pulp, and that means a broken tooth with an open canal, that may mean a discolored tooth that we've had pulpitis that is not resolved and the pulp has become non-vital. We might see we've got this abscess on this 108 upper fourth premolar here that was actually due to a non-vital pulp, but wasn't very apparent. Okay. Or we'll get little dogs that have periodontal disease on the palatal root that ends up getting infection into the pulp through the apex and killing the entire pulp. So we need to look at that compromised pulp. I do like using something called transillumination to look at these teeth to evaluate them. Obviously, that dark purple tooth needs extraction or root canal, right? But sometimes it'll be a little not so sure. Maybe we're trying to talk owners into it. I can use a bright pen light, shine it from the back side of the tooth, and if it's vital, you should see the pink of the pulp in the center. You shouldn't see it darker. You shouldn't see it diffused. So that's just one neat way in addition to radiographs. We certainly are going to be talking about extractions for tooth resorptions. And as we look at the two different types, in fact, odontoclastic or replacement resorption is type 2. If it's just in the roots, we probably don't have a lot of issues. We'll see that x-ray where the periodontal ligament space is not visible. Once it extends into the crown, then we need to treat. We need to extract. And we'll talk a little bit about the differences in extraction in a bit. With inflammatory or type 1 periodontal disease, this is actually roots that have been exposed due to bone loss, gum loss, exposure of the roots. Now we get resorption due to the inflammation, but the roots look intact. I can see periodontal ligament space in this lower right radiograph. Those have to be extracted completely. It's not fun when you see that intact root, but these are only about 5% of those cat teeth. We will also see tooth resorption in dog teeth as well. So, making our decision to extract. We look at the tooth. We look at the extent of disease that's going to decide whether or not, yeah, it's too diseased to keep, and its relative importance. If I had a broken incisor with open canal, I doubt I'd be recommending a root canal, okay? But if it's a lower canine, that's a different picture. We also look at the patient. If we're older with systemic disease issues, especially with anesthesia, I'm more likely to extract than to do some fancy periodontal surgery or a root canal procedure. And then certainly we'll also look at the client. We might have to look at compliance with home care if this is a periodontal case, coming in for regular rechecks, maybe treatment every 6 months, and it may even be a cost issue. Now, they are rare, but sometimes you have those unicorn clients that will do everything you say. They will get on that brushing program. They won't complain about the bill, and they even bring you cookies later, right? There's a few of those out there. We actually categorize our clients, and more of our clients fit into the narwhal category. Now, there's the unicorns of the sea, and they're still pretty special. They'll do a lot for their patients, but you know what? They're sometimes a little bit challenging. So, yeah, you prefer the unicorn over the narwhal, but narwhal is still reasonable. All right, we're going to look a little bit of equipment because, yes, the right equipment makes a difference. I prefer the cross-cut Fisher burrs that have a bit of a taper, the 699 to 701. Some people like the straight cross-cut, such as the 557s. Now, size does matter here and in a couple other instances that we'll talk about equipment. When I look at the 701 that's good for sectioning large dog teeth, it's going to be too much for a small cat tooth. So I'm going to go with a 699 that is second from the right on the bottom as compared to 701. A lot of people may prefer the surgical length in the shaft of the burr or even the surgical length of the cutting edge. Here we have 701 with surgical length of the shaft, 700 with longer cutting. These longer cutting edges kind of tend to break a little bit more easily if you're not careful. The longer surgical lengths of the shaft allow you to get into tight spaces a little more readily, but it is harder on the turbines, so they need good care. And remember that the water spray isn't going directly to that cutting head, so just be aware of that. In addition, we might use some round burrs for alveoloplasty, for removing some bone before our surgery, or even rough pieces of bone. And I really like diamond burrs for smoothing that bone, the alveolar bone, before we get ready to close. 12 fluted burr, I'm going to be using more for soft tissue, such as mild gingivoplasties, and taking it from there. Now, I could not practice well without good periosteal elevators. My favorites are the flatter molt number 2, molt number 4 that has one on each side. Sislac makes a really good one, the EX2021, I think it's still called. They also make a serrated version, and I call it my scrapey thingy if I have to debride out any kind of tissue from the alveolus. The thing of it is, I like the flat ones. There are some that look a little bit more like a spoon, a little bit curved, and those are fine. And some people like larger elevators too, like freer periosteal elevators. But I like these small, fine ones for lifting that gingival margin. And I'll tell you about a little way I cheat with them as well later. So, dental elevators, in theory, there's winged type elevators with the curved edges that help cup the size, the diameter of the root. And again, that winged elevator should be the same size as the root you're trying to take out. If it's too small, it won't be effective. If it's too large, it might not even fit in the alveolus. A luxator is a flatter version of an elevator. In theory, in the human dental world, it's a little bit different. But as we look at these, the important thing for all of them is they must have a sharp working end to it. There must be a very nice tip to it that's going to fit in the periodontal ligament in between tooth and bone. If you don't regularly sharpen your elevators, you're going to be working too hard, all right? Because it's not an efficient instrument. As we look at these, the best place they are used are in that periodontal ligament space in between tooth and bone, and then used to lever to fatigue the periodontal ligament space, the periodontal ligament itself, to help get that ligament fatigued enough that the root comes out of the socket. All right? Pictured below is a periatome from Gervet that has some serrations on the ends. It's a nice, durable, flat type of instrument for luxating. So sharpening is critical. And there's probably 12 different ways to sharpen. I know other people have other methods that they like. I'm not real coordinated with sharpening the outside of it on a flat stone, but usually all you need is a flat Arkansas stone to do this. I like making rounded edges to where I sharpen the inside portion of it to where I do have a little bit of a knife edge there. Now, once you've sharpened these instruments, you need to make sure you hold them correctly with your finger right at the tip of the instrument. So if you do go oops, you don't cause a lot of damage, because be careful with these. And by the way, you can't have these done once a month by the scissor sharpener guy. You have to check these after every use. There are some times when I'm doing multiple extractions, hello yesterday, where I need a different elevator that's sharpened because I've been using the one for that particular size to where it's become dull already. So sharpness is very critical. General equipment, I like smaller. I like the small breed extraction forceps. With my elevators, they have some smaller shafts that fit your hand better. I like the 15 or 15C blade, scalpel blade on a blade handle. And then for suture, the monofilament, I'll typically do 4/0 for dogs, 5/0 for cats, reverse cutting needle, maybe tapered in cats. Occasionally on a large dog with a lower canine that they just love to rip out the sutures, I might go up to 3/0, or at least with a mattress suture there. But the monofilament, the polyglycaprone, is typically my favorite because it doesn't drag. Some people like using catgut because it's going to dissolve quickly, but I think it starts getting a little bit draggy after 2 to 3 passes. Now, I'm sure you know we all love good pain management. Absolutely. Perioperatively before it starts. If you have a painful pet, get them on pain medications prior to the procedure. We send home Serenia. Yes, more for the nausea, but we know that substance P is kind of special. Multimodal, as we're looking at the day of, are they appropriate for NSAIDs? We're certainly going to be using an opioid in there. We might use benzodiazepine depending on the patient itself. Unless it's contraindicated, a low dose of that alpha-2 is going to smooth out anesthesia, recovery, and enhance pain. And certainly we're going to be looking at blocks and continuing with post-operative pain management as well. A brief little preferences for me on local blocks. While lidocaine is quicker, it doesn't last as long. I prefer something like bupivacaine as long as I can get it, and so far so good. I like the 0.5%, and at times I will use the one that has the epinephrine added to it. It's a little harder to get, so I typically save it for specific things. Don't use it if contraindicated due to heart rate, hyperthyroidism. In theory, you could cause some ischemia. I've never really experienced that myself, but I do know I stick with 1 mg per kg for cats, 2 mg per kg for dogs. Now, the adage of adding lidocaine and marcaine together to make it work faster, but it really doesn't work that much faster, and it does decrease the duration. All right, so I just make sure I identify the places early that need blocks. I get the blocks in early. In fact, Vanessa is my vet tech, VTS dentistry, that she does after getting the patient stable with the monitoring. She gets all the radiographs done first step. That way I can evaluate what teeth we're probably going to be extracting. We might chunk off a little calculus there, but we're not going to make them pristine clean with polishing before I decide which ones I'm going to extract. We're not going to waste that anesthetic time. So I like getting the bupivacaine in there early. Now, bupivacaine with the liposomal, with the Nocita, I have used quite frequently in dental blocks. I tend to use the same volume. And then we'll be looking at about 4 days worth, up to 4 days rather. I will also sometimes look at potentiating with buprenorphine. So my typical will be 0.1 cc of that 0.3% buprenorphine. and with about 0.9 of the Marcaine squirted into that 0.1 to mix it up well. I just do try to watch total dose overall if I'm using buprenorphine on different levels. So as we look at intraoperative blocks, I know, and there's some studies looking at dye studies with infraorbital with cats that still show a good infiltration there. I tend to do a caudal approach to the maxillary block, and I'll show you that in just a bit. We also look at the caulomandibular block or the inferior alveolar block, but we need to know the anatomy. We need to know where the nerves are. We need to make sure we don't damage anything. All right. And the reason why I've changed from infraorbital is that since you're not supposed to go any further than the medial canthus, well, on a brachycephalic or cat, the eyeball's right there, right? So I've started doing a caudal block, but not coming in just behind the last molar and aiming upwards, because there has been a globe injection using that method. I actually come with the needle and syringe parallel to the palate, slip it underneath the zygomatic arch to get back to that pterygoid fossa, which is the backside of where the infraorbital canal is. But then I also infiltrate as I come back out, because that will now block the molars and even the fourth premolar, especially on a cat. So watch for that. Get skulls. Regular dog, cat, brachycephalic dog. That way you have good landmarks. You can even illustrate to owners what you're going to be doing. So it's just a good teaching tool and a good supportive tool as well. You know, if you're not comfortable with specific regional block, at least put some material in the alveolar mucosa above the tooth itself. Now, this will help block the soft tissue if you're doing a flap. Maybe you put a little bit more around the bone or alveolus once you're started the procedure, but get some block in there. It can make a big difference in reducing the MAC concentration, keeping them much smoother, and having them more comfortable after surgery. X-rays are absolutely imperative. It's good medical legal documentation. You're going to see if there's abnormal roots and the abnormalities in the bone. The most important thing I look for is the periodontal ligament space. If I see a good periodontal ligament space, my chances of having a more normal extraction is higher. All right. If I don't have a good periodontal ligament space, if I have tooth resorption, if I have ankylosis, then doing an uncomplicated extraction without a lot of sweat, that probably won't happen. So those x-rays are extremely, extremely important. And then as we do our extractions, I'm not sure how many of you guys got excellent teaching at the university system. Most of us didn't. Most of us, it's learning as we go or going to seminars or listening to webinars. But the more you get familiar with the step-by-step, the systematic, almost like body memory, then things come a little bit more easily. And this includes, in the great majority of cases, doing a gingival flap with the release. I know some people say they can do all extractions with just an envelope flap, no releasing incisions. They must have skills I don't have. I like good access, not extreme access, good access. We have to be able to section the teeth, maybe take out some bone so we can see the furcation. We're going to be elevating those two segments by fatiguing that periodontal ligament. And then once it's all out and we're happy, then we're going to get everything ready. We're going to elevate the lingual palatal side, smooth out the bone, suture. Sometimes we'll pack the alveolus with material and take it from there. So as we look at the gingival flap, I like the 15C blade. One thing I like to do first is I don't think I have a drawing. Oops, sorry about that. Going to go back up. Annotate. Here we go. I like to make a thin cut right on the gingival margin. Okay. That way, I already have my freshened edge. I don't have to do it later, right? And then I'm going to make my releasing incisions. I typically like a pedicle flap with 2 releasing incisions. straight up and down mesially, say at this, a couple millimeters past the mucogingival line, and usually angled a little bit further back past the mucogingival line to make sure I get where that big, thick root is curving. All right? Once we get to that flap, let's see, there we go. Here's my maxillary canine. My maxillary fourth premolar, I can usually get by with one mesial incision. Of course, trim the line, the margin, and then this triangle flap is usually going to be able to reach that palatal root when I freshen it up, when I release it and get ready to close. Some people like doing an L-shaped or triangular flap on the upper canine because of where some of the blood supply comes from, usually distally. I'll be honest, after 40 plus years of doing a full pedicle flap, I haven't lost blood supply. I've had dehiscence due to fun dogs that chew on things that they're not supposed to chew on, or in cats sometimes with tumor that was underneath there. But from blood supply itself, not so much. So I'm going to erase my little lines here. All right. So next, it doesn't want to, there we go. Lower canine. Probably one of the least favorite extractions out there. And because it's such a big root, we don't have as much bone as we do have in the maxilla. I mean, maxillary buccal bone, I could take the entire maxillary buccal bone off for better exposure. I usually don't. I like to keep bone. But in the mandible, this tooth is a good portion of the strength of that jaw. As we look at that tooth slightly going medial, what I like to do is I like to get flaps that allow me to approach a little bit on the buccal, a little bit on the lingual, but definitely on the distal aspect of this tooth. So I'm going to be making a typical mesial incision. Then I'm going to be making a distal incision, kind of following that where that root goes, usually back to the first premolar, and then an incision buccally and a small incision lingually. That way I can get to all aspects of this tooth. So here with our full buccal flap, we can get that. But by coming distally, and I can even cut it back a little further distally, I just don't like cutting through this frenulum here. But now I've got access to the lingual bone, to the distal bone, and to the buccal bone. One important aspect that I'll cover again later on is as flat as this tooth is, on the lingual side, there is less bone than on the buccal side. So I will use my flat elevators inserted into this periodontal ligament space and rocked more like this. I don't twist them. I rock them back and forth to help start to separate tooth from bone. And using those flatter elevators can be very helpful. Now here's where I cheat just a little bit. This the periosteal elevator is a flatter one. And you can see the one on the left side of the picture. I can even gently insert that periosteal elevator in between tooth and bone and do the back and forth just a bit, okay? Now, this is a very thin piece of metal. You can bend it, you can break it, all right? So we have to be careful there. But having a flatter luxator to be able to loosen those sides can be very important. Real quick question for Mary. The caudal opening inferoral canal is the pterygoid fossa, PTER, kind of like a pterodactyl. All right. So let's keep going. As we elevate the flap, and usually my finger is right on the edge of this instrument. I moved it aside to get a photo. Remember, that corner is sometimes the hardest part to elevate. Make sure you've cut through all of that gingival tissue with your blade, because that's where it's thickest. If I can get in at that corner, that's a good start. If not, I'll come from the gingival margin, but I can come from the sides too, all right? And as I get that periosteal elevator under that, I make sure I'm above the bone and underneath full periosteal flap and gently wiggle that up until I get at least a couple millimeters beyond the mucogingival line. Now, one reason that I started looking at using my flat periosteal elevator in between tooth and bone is that I noticed in some labs that we did with specimens, some people would get that flat elevator in between tooth and bone. So it got me to thinking. So I usually can't claim anything on my own, but I'll use things from others all the time. Now, remember I said you could take out all the buccal bone over this maxillary canine for easier extraction, and it would make it easier. I like keeping bone if I can. So I will get it at least as far as the widest part of the tooth, okay? So maybe a few millimeters above the mucogingival junction. If it doesn't loosen up, I can make the flap taller, make it longer, and take out additional bone. But I do like to preserve whatever bone I can. The best part, and I usually do this right now, some people will do it right before closing, is releasing those periosteal fibers. Remember, we did a full thickness off the bone. Now we've got periosteum on the underside of this flap. Periosteum is not elastic. So if we were to try to suture once this tooth is out, that piece of tissue would just go right back where it was, and there'd be tension on the sutures. So we need to come with scissors, some people like blades, and we need to snip across to make sure that we separate the periosteum from the attached gingival part to the periosteum that's going to remain closer to the bone. And on an upper canine, this is where it's the most fun, where you start snipping and it just releases completely. Makes such a difference. This is extremely important when you're looking at any tooth that has ornate fistula, bone loss into the nasal cavity. Now, as we look at this large tooth, remember the root is wider than the crown opening is, all right? So I'm going to use either a crosscut fissure or a round burr. I may shave off that buccal bone. I'm going to make ditches or slots at the rostral mesial aspect of the tooth, at the distal aspect of the tooth, really following where that periodontal ligament is. I'm basically making a really large periodontal ligament that will make it easier for me to put my elevators in, all right? Now, we want to expose the root at its widest. So here's my bad joke for today. Big root, small opening of the crown. You never want to take something larger out through a smaller hole unless you've had an epidural and can name it afterwards, okay? Gentlemen, if you need any explanation, just ask your wives or your co-workers there. If it starts loosening up when I start elevating, I have enough bone gone. If it doesn't, I can take off more bone. If I remove this buccal bone and see that it's not quite giving at this buccal bone aspect or even the paddle aspect, that's where I'll get my flatter luxators to go in there and separate that periodontal ligament, making a little bit more space in between tooth and bone. All right. The mandibular canine, remember, is quite special. I tried to take out a little bit of lingual bone. I tried to take out some distal bone and some buccal bone. Again, using my luxators on the lingual and buccal sides. I will even take off a portion of this crown so I can get my winged elevator following that root. All right. Once I've got that winged elevator down that root in between tooth and bone, then I can do some rotational forces. Okay. Always cupping the mandible with your other hand, really supporting it well. Now you can also elevate in between the incisor and canine tooth. Be careful right there. My main focus is on the tooth and the jaw at this point in time. If the incisor happens to loosen up or the premolar happens to loosen up, they get a complementary extraction. They're not big on my list of priorities, so to speak. Now, as we remove alveolar bone, we did some with the maxillary canine, we did some with a mandibular canine, but I also want to remove some of this alveolar bone to expose the furcation. I want to make sure when I'm sectioning a multi-rooted tooth, I'm really sectioning it at the split. On top of everything else, once you have the tooth out, you'll probably be smoothing off that bone anyway. So take out enough that you can visualize your furcation. All right. As we look at, do we need to take out more bone eventually? I'm okay taking out any of the buccal bone of the maxillary teeth, just watching that infraorbital canal area. And I can use a crosscut fissure burr like windshield wiper, taking out that additional bone. On the mandibular bone or mandibular teeth, I actually prefer to take out the bone that was in between the roots, the interseptal bone, especially say behind this mesial root of the lower first molar. And I'll show you a little bit of a different aspect that I do nowadays. You can take out this bone that was behind the root to get better access. All right. And that can sometimes help you out quite a bit. Sectioning teeth, I like coming from the furcation up through the crown. Obviously, this is on a specimen. That's why I'm so good at hemorrhage control there. But as I'm looking at this, I'm using the entire length of this crosscut Fisher burr, and I'm coming from the furcation up through the tooth, adequate water spray. You notice I am protecting my soft tissues with a tongue depressor, actually using a tongue depressor. There's some other devices now that we can use as well. With this lower first molar, I'm going to be sectioning from the furcation to that developmental groove, but I'm also coming from the furcation mesial, and I'm going to take out an entire wedge of that lower first molar. You can do it with any premolar, even the smaller ones. With my upper fourth premolar, these are important steps to go from the furcation to the developmental groove. Then I'm going to go down here from the furcation forward. I'm going to take out that entire section of crown so I can visualize the roots better. I'm also going to gently shave the distal cusp because it's very tight against that upper fourth premolar. In fact, let me go back up. I'll shave the mesial cusp of this first molar, so I have space between it and the fourth premolar, or I'll gently shave the distal cusp to make space for my elevators between the second and first molars. The other reason why I really like taking out this section of crown is now I can actually see where the furcation is between the two mesial roots, the mesial buccal and the mesial palatal root. And this furcation is not right over the cusp of this tooth. There's a V-type shape when you get this section of the crown gone that you can see, and you're going to connect the back of this V to the V that's at the front and cut all the way through. If you don't make this all the way through and you start elevating, usually you're elevating that mesial buccal root. It snaps off and you can see exactly where there's still furcation left of bone until you get to the furcation. So this is the best way I like to visualize sectioning these teeth. If you have to take out the maxillary first molar, I usually don't make a flap here because it's fairly narrow for how wide it is into the palate, all right? We'd have to make a very narrow flap and loosen it so it goes very deep. Number one, there's salivary ducts around there, okay? Number two, a study was done. As long as I get a good section, a good suture behind the upper fourth premolar, I like looking ahead and making sure I'm going to have a good collar of attached gingiva around that remaining tooth. And then maybe a cruciate. It won't bring all the edges together, but the blood clot has shown to be stable enough for these teeth. Now, one thing that might make it easier if you have to remove the second molar, then pulling all that soft tissue forward is a little bit easier. Just don't forget to section these teeth into 3 roots. I don't care how loose they are. You might have to hold it still to section it. And actually, it's almost easier if you know you're taking out on both sides or whatnot. It's almost easier to section it across the head. I am a lateral position person. Some people like dorsal positioning anyway, so you can do it that way. But please section these because if you don't, no matter how loose they are, they're going to have a root with a hook on it that's going to break off, and now you're going to have to go get those roots. So section always. So we've done the flap. We've sectioned the teeth. Now we're going to talk a little bit more about elevation. So as I start out, I like starting out with a flat luxator with a sharpened edge, sometimes smaller ones initially, and then building up to larger ones. We don't use these in rotation. We just kind of, almost like a windshield washer, again, kind of back and forth within the periodontal ligament space. There are mechanical ones. There are piezotomes that are absolutely amazing. If you can get, that's fine, but not everybody has them, so we have to use what we can. Now, if we have a simple extraction, not necessarily that upper canine, although older cats with the osteitis, sometimes it is kind of simple. But say a first premolar or a last third premolar, third molar on the mandible. If we have one root, if it's already got periodontal ligament, we might not even have to do a envelope flap. We might just be able to elevate that out. That is an extraction. Anything else that has a flap or sectioning of a tooth or taking bone away is oral surgery. And to me, that's a great definition for what a veterinarian does, oral surgery. That's a great way to approach it when you're talking about the estimates with an owner. It's not just pulling a tooth, it's oral surgery, okay? And some of it can be quite challenging. Tell you what, a lot of teeth with tooth patients yesterday pretty well did me in. I had to rest last night. As we look at elevation forces, we should be very deliberate. We should be controlled. We should have the elevator tip close to our fingers. We're advancing apically anytime. It should be not necessarily gentle, but firm, but steady force, okay? Remember, the periodontal ligament space is fairly thin. We need to have that sharpened edge. But once we get that edge, the tip of either the luxator, then going back and forth, or the winged elevator to where we can sit there and rotate and hold and move that crown, that tooth, that root within the alveolar bone, stretching that periodontal ligament, and then pressing it another way, coming to the distal aspect. Then we can work around the tooth, getting that ligament loose enough to where we can remove that tooth. Going in between two segments as a fulcrum is not very helpful. In between an adjacent tooth is not very helpful, because as you do any kind of leverage on the crowns, the fulcrum itself is with the roots under the bone, and that's where we might have root fractures. So in between roots, not that great, you know? And if you're really pushing in this area, especially with molars or premolars, watch to make sure you don't have the oops. We've had issues with infraorbital canal. There's been issues with orbital penetration from extraction and bleeding periorbitally. Even a case of brain lesion, which was a big oops, but I think that was quite an old article, so hopefully it hasn't happened much since. Now, as we look at getting some laxity there, some stretching that periodontal ligament, I like to use a small extraction forceps, gently grasp it, and do a slight turn and hold, slight turn and hold. Guess what? That can help fatigue that periodontal ligament, but it can also help tell us where it's not fatiguing enough, where we need to do additional bone removal or elevation. And in practice, when we're doing labs and things like that, of course, you don't have that bleeding, but with your patients, if you see the bleeding in certain areas, but not in a particular area as you're doing this slight rotation, that's where you need to concentrate, all right? I just would be very careful, say with maxillary canine teeth that could rotate into the nasal cavity. Most of our premolar and molar roots are somewhat conical, so it's not as much of an issue, but I do like this slight rotation to help fatigue the ligament, but also tell me where I need to work more. So be careful about how you elevate with these upper maxillary canines, especially on smaller dogs. There's not much palatal bone before we get to that very thin alveolar bone in between tooth and nose. And most times, I like to say we don't necessarily cause an oronasal fistula. Maybe we just reveal a previously inapparent oronasal fistula. Well, then we just close it appropriately, right? So as we finish, make sure you elevate the lingual or palatal aspect, all right? Because we want to be able to smooth out that lingual or palatal bone, and we also want to be able to do sutures, bites, without having to struggle against bone. I like smoothing out this alveolus with a diamond burr, making it really smooth. I might use my round burr or even my crosscut fissure if I really have big chunks, but I don't want bony spicules. I want it very, very smooth. And even when I get good release of tension, possibly that bone level just a little bit lower than the surrounding areas, so it's not causing too much tension there. Now, using osteopromotive implants can be a personal preference. I don't use it very often. If I have a smaller dog with a lower canine or lower first molar, where I feel that some benefit from either with a console providing a scaffold, I'm perfectly okay with that. It doesn't go away. You don't have just bone there, but I think it helps provide bone fill to even more expensive products that are like allograft. They changed that name on that one, that are actually demineralized freeze-dried bone products. It depends on the case, sometimes the cost as well. When we're doing our sutures, we want to minimize tension. So if we haven't already released that periosteum, we're going to do it now, and we're going to replace that soft tissue over the extraction site, let it go, and if it stays there, then we don't have tension. If it tries to shrink back, we need to release a little bit more tension there, so we have a tension-free sutures. Now, stealing from Franklin Covey, I like to start with the end in mind, begin with the end in mind. What is our goal as we're looking at extractions? Because we're usually not just extracting one bad tooth, we're usually managing the periodontal disease around an adjacent tooth, especially when we think about the big eight, canine teeth, upper fourth premolars, lower first molars, all right? So I'm going to look at strategic tooth removal. So my apologies for not having the radiographs. This overall, this 408 maybe had 35% attachment loss, which isn't yet full stage 4 periodontal disease, but most of that bone loss was in between that tooth and 409, definitely putting it at risk. We can't clean well there. So I'm going to sacrifice this 408, the smaller 408, to make 409 healthier. We'll also look at a couple slides later that shows as we look at the soft tissue management, we want to make sure we keep healthy tissue. We want to remove any diseased soft tissue, and I want to make sure that I can get good access for cleaning, maybe for packing some osseous graft material, and even membranes, and to making sure that I have a good collar of healthy attached gingiva around that remaining tooth. So start with the end in mind. So with this, I'm not going to be cutting back here in between 408 and 409. I want this to be relatively healthy, continuous attached gingival collar. So I'm going to make an releasing incision in the mesial aspect of 408 for exposure of 408 and just far enough to expose the periodontal pocket in between those two teeth. All right? So I'll be able to take that tooth out. Now look at the exposure I have. If I had not taken out 408, there's no way I could have cleaned 409. All right? This one has maybe just very slight infra bony pocket, but most of it, I really can't put too much bone graft material in there, but I can now clean it out very well. The downside is I still have some root in there. All right? And as I start going for the root, you know the mandibular canal is pretty close to this area, right? Well, luckily all bleeding stops eventually, but when you're trying to see what you're doing, it can get in the way quite a bit. So as I'm ditching out a little bit of bone to get the remaining root out, I start getting some pretty good hemorrhage, okay? So in order to be able to see in there a little bit better, and I still had work on other teeth, I've gotten some of that molar cleaned off. I went ahead and got the Vetagel, that's that hemostatic gel, and I placed it in that alveolus, and you can use a moist gauze on top of that, and it basically helps promote hemorrhage control with fibroblasts so that it wasn't a pulsing arterial from the mandibular artery, it was a lot of oozing, all right? So I placed that in there. I did the damp gauze on it with a little bit of pressure, just very little. And then I had a little something else to do somewhere else. Came back. The gel was in here, just a little bit of oozing. I was then able to remove this. Now, if I didn't have a root in there, I would have just sutured up, okay? But since I did have a little bit more work to do, I went ahead and removed it quite easily. I was able to access that root, get it out. You can see how much cleaner it is. Finish cleaning that tooth. I smoothed off that bone. And now with my suture, although I have a slight mucosal tear, do you see where the gingival, attached gingiva, is now lower on this tooth, directly over the bone? Well, we had lower bone levels. Yes, we have root exposure, but we're not going to have a pocket. We're going to have a much healthier situation. Even though we've got periodontal disease with attachment loss, we're not going to have that deep pocket anymore or that adjacent tooth. Home care is possible, additional care is possible. So I will do more around those important teeth to keep them healthier. And one part where this is extremely important is when we're looking at our mandibular canine teeth. So often we'll get pockets there, certainly due to periodontal disease itself around the tooth, but usually with adjacent incisors. Sometimes we've even had those mouths where the incisors have been gone for a while. Now we've got all these flappy gums, redundant tissue. Well, it still will make a pocket there. So I will definitely come in and do actually cutting down through this tissue. It's called internal bevel, to remove all of this diseased tissue when I'm extracting. Root plane it well, open root plane and get it in. If I have an infrabony pocket, I might use some bone graft material. I'm definitely going to be doing some bone contouring somewhat. And when this is closed, again, the gum tissue will be lower on the tooth, but it's going to be a healthier tooth. We'll also see some conditions with unerupted lower canines, or under-erupted, sorry, brachycephalic breeds where the incisal bone is much higher. And by removing those incisors and bringing that gingival tissue down, we're going to have healthier teeth. And there it is after removing the diseased tissue, the diseased tooth. Now we do have root exposure. I mean, we're not going to get that back. We're not going to get that bone and that gum tissue back on that tooth. People have procedures at times that they can do, but we certainly have a healthier situation. So just briefly about some complications, root tips, using root tip picks, using more bone removal. If I have ankylosis, I don't pulverize, but certainly if I have root tips, especially on that lower jaw, I will take out the bone that was in between the roots and try to kind of press them back and forth, all right? If you use too much apical pressure, and there's bone loss at that apex, you might pop it right into the mandibular canal. And one of those teeth did that for me yesterday, and I just took out a little bit more bone and kept flushing, and luckily the root tip popped out. So that can be a bit of a challenge, but you can handle it. The key is, especially if it's a smaller dog, luckily this is a bigger dog, we don't have as much jaw. And in fact, if we've had periodontal disease, we've got compromised jaw. Try to maintain the lingual and the buccal cortical bone plates whenever possible. Remember, on the maxilla, I'll remove whatever maxillary bone I need to. But I don't want to do that with the mandible, especially on a smaller patient. So I'll create a ditch, okay, to help remove some of that interdental bone, interseptal bone, and be able to approach it from the rostral mesial side and distal side, all right? And anytime you do have a small pet mandible with extreme bone loss, say the lower first molar, you've got that x-ray and you're kind of going, I don't think so. Let the owner know. I don't like to say I might break your dog's jaw. I mean, sometimes that's applicable, but it may be fragile. You can always offer them a referral, even if it may not be close. Let them decline the referral and put it in your notes. And then if something does happen, you can show that you offered the referral. So lost root tips, such an amazing feeling when this happens. We can do it in the mandibular cavity. We can do it in the nasal cavity. And the key is, as you're looking at it, it's easiest to retrieve the tip right then because this is the loosest it's ever going to be because it hasn't gotten fibrosed. It doesn't have a lot of granulation tissue around it, all right? So I'll gently enlarge the hole it fell through and flush, flush, flush. It's difficult. We do have some forceps, so you can reach down in there and get it, but sometimes it's like bobbing for apples. Sometimes it just makes it move further. So it's kind of a pain. So flush, flush, flush. This one, we actually had to take out the bone that was in between the two roots. There, opened up a nice window and we're able to get it out. All right. I will also put a little additional local at that point in time down in the mandibular canal because I know I've been at least touching the nerve and, sometimes that artery. Just a couple things with tooth resorption. If you definitely see no periodontal ligament space, if this is a replacement resorption where bone cells have come across that periodontal ligament space and it's turning tooth into bone, replacement resorption. In people, if we have resorption in the roots, there's typically no discomfort, but when it starts entering the crown itself, that's where we have discomfort, all right? So I will still put a local block, do a little gingival flap, section it, try to elevate it. You might be able to see a little bit of periodontal ligament space on this measly root of 307. I might get that portion out. Sometimes I've gotten it all out. That's been kind of cool. Usually it doesn't. Usually it goes crack. So that's when I'm okay with smoothing it off, elevating your lingual portion, closing it up. Sometimes a cruciate is enough, and telling the owner resorbing root is retained. We'll continue to monitor. And this has been shown that it's a reasonable way to go about it. However, if that 5% of cases, it shows that there's intact ligament, intact root, distinct roots, you have got to get those out completely. In fact, this one, due to periodontal disease, has caused such crown resorption that we now have bacteria that's gotten through to the root and has caused endodontic bone resorption, which is still periodontitis, by the way, apical periodontitis. You can't just crown amputate this one. In fact, I like the term modified extraction. You need to get all of this root out, all right? And that might be challenging. That's when you find your patients. That's where you get your smaller feline elevators and root tip picks. And just take your time. Take sequential x-rays to find out where that root tip is. The one that fell into the mandibular canal the other day, I used a small needle to help me locate exactly where it was and get those roots out, okay? As we talk about finishing up, we talked about finishing the and suturing. We also want to finish the patient, right? We want to send home with good pain management. A lot of my cats these days, I'm using Zorbium, really like that. We look at motomodal as an opioid appropriate, as an NSAID appropriate, depending on their renal function, things like that. Don't forget common sense kind of things. Cool compresses can help if they seem to be uncomfortable, they'll let you do that. We also like to get our clients, we'll actually encourage them to go online and get one of the dental loops prior to surgery, especially if there's inflammation and pain, and they can get it started ahead of time, and then they can continue that post-operatively as well. So the dental loop is a little bit smaller. It has a specific 60 type treatments in there. The size chart for the neck circumference is with the bonnets that they use. I'll be honest with you, I've been using just the loop itself, okay? And Caitlin, remind me, I'll do your questions about the local blocks at the end of the conference. But this has been really helpful for any post-operative. I've been using quite a bit with my stomatitis kitties as well. The reason this helps out is, number one, it's not another prescription that I have to put down the animal. Now, I did have one lady who said, yeah, she had a little bit of trouble getting the loop over the cat's head. I went, no, you just have to hold it beside it because it's like this barrel. But it helps upregulate natural nitric oxide production that helps increase blood flow, modulate some of those cytokines. We have decreased pain and edema. So we have a more comfortable patient. There's been some good studies. I'm getting a little bit behind, so we'll go through this quickly with hemolaminectomies. I mean, that's pretty major surgery. And there was reduction in needed opioids, quicker return to healing. This is a lot of the things I see with people too, using the targeted pulsed electromagnetic fields. So this loop provides a barrel, like I said, on either side. Each treatment application is about 15 minutes. I usually tell them to do about 2 a day. So with a 60-day application in the dental loop, that's about a month's worth, okay? And if they really feel there's been some benefit, they can get one of the larger loops that last quite a long time, or even the lounges as well. So post-operative, but also chronic pain management. We see some animals TMJ issues. We see some possibly neuropathic pain, things like this. We're certainly going to look at whatever's going to be beneficial for that patient. All right. So we have lots of options out there. Here's the loop lounge that can be extremely helpful with kitties, and then they have larger ones as well. These are rechargeable, so you can use them almost as often. And I can't deny the fact that when my bursitis flares up, it happens to show up close to my couch for some reason. I have no idea why. But,